Good evening, everyone. I am Robert Subtirelu, a third-year medical student at the Pullman School of Medicine. Today, I'll be discussing the use of Positron Emission Tomography PET in Anterior Temporal Lobectomy, or ATL, for temporal lobe epilepsy. The talk is inspired by a recent study, which was a collaborative effort across several institutions, including Sidney Kimmel Medical College and the University of Pennsylvania's Department of Radiology. Imagine suddenly losing all awareness of your surroundings. One moment, you're completely present, and the next, it's as though you've vanished from the world only to come back minutes later with no memory of what just happened. This disorienting experience is the reality for millions of people worldwide living with temporal lobe epilepsy, or TLE. TLE is one of the most common forms of epilepsy, affecting more than 50 million individuals globally, including over 400,000 people in the United States alone. The causes of TLE vary and often include factors such as head injuries, infections, tumors, or even genetic predispositions. For these patients, a typical seizure begins with an aura, a warning phase, where they might experience strange thoughts, feelings, or sensory changes. This is then followed by a vacant stare, motor limitations, and sometimes repetitive movements, known as automatisms. For patients with temporal lobe epilepsy who do not respond to medications, anterior temporal lobectomy, or ATL, has emerged as a highly effective option. This neurosurgical procedure involves removing parts of the anterior temporal lobe to control seizures, specifically targeting both lateral and mesial temporal structures. Depending on the case, these structures may be removed together or in separate sections. Research shows that ATL can successfully control seizures in up to 80% of patients, making it one of the most promising medical interventions for medically refractory TLE. However, as with any surgical intervention, ATL is not without its risks. Removing part of the brain that is closely tied to cognitive functions, particularly those in the temporal lobe, can lead to potential declines in memory, language, and even changes in personality. Precise localization of the seizure focus further reduces the risk of post-surgical seizures. To target the exact epileptogenic zone, two main techniques are used: magnetic resonance imaging, or MRI, and electroencephalograms, or EEGs. MRI is valuable in identifying structural lesions that may contribute to seizures, but it has limitations, particularly when no structural abnormalities are visible. In such cases, MRI can fall short of pinpointing the exact seizure focus. EEG, on the other hand, is effective for detecting surface-level brain activity. However, it faces challenges with deep-seated seizure foci, particularly within the temporal lobe, often requiring more invasive methods like intracranial EEG. This technique involves placing electrodes directly on the brain's surface to capture activity in hard-to-reach areas. Additionally, EEG data is limited to the recording period, meaning it may not capture all seizure activity. This brings us to the need for a non-invasive method capable of detecting non-structural abnormalities. PET imaging has become a game-changer in the pre-operative evaluation of TLE. Positron emission tomography PET is an advanced imaging technique that detects metabolic activity within the body by using radioactive tracers, typically injected into the bloodstream. PET is highly effective for visualizing functional processes in the brain, such as glucose metabolism, making it valuable for identifying abnormal regions that standard structural imaging may miss. The need for PET lies in its high sensitivity and ability to detect non-structural abnormalities non-invasively, addressing critical gaps in pre-operative planning for ATL by accurately localizing seizure foci, addressing the extent of TLE, and predicting post-operative outcomes like seizure recurrence and memory changes. Our approach involved a comprehensive literature review, drawing from PubMed, Scopus, and ScienceDirect to evaluate studies assessing the role of PET in localizing seizure foci and predicting post-operative outcomes in TLE patients undergoing ATL. Studies included in the analysis were those that provided detailed comparisons of PET imaging with other diagnostic tools used in pre-surgical evaluation. The selection criteria prioritized studies that offered quantitative data on the influence of these modalities on surgical decision-making. One of the key findings in our study is the high sensitivity of PET imaging, specifically FDG PET, in localizing seizure foci, with a sensitivity range between 75% and 93% across studies. Notably, research shows that PET's accuracy varies depending on the epileptogenic zone's location, around 80% from temporal lobe epilepsy, for example. PET becomes especially valuable when combined with MRI and EEG, significantly enhancing localization success. In fact, some studies report that PET can detect seizure foci in up to 100% of MRI-negative cases, emphasizing its critical role in cases where traditional imaging doesn't provide clear answers. On the right, you will see the FDG PET scan of a patient. A demonstrates quantitative analysis of this PET scan. B displays fused PET CT MRI image. Arrows in C demonstrate focal hypometabolism in the right parietal lobe, and D showcases an MRI highlighting areas suspicious for focal cortical dysplasia. You'll see this with the arrow, and this is coincident with the area identified on FDG PET CT. We also found that PET imaging can predict cognitive and seizure outcomes after surgery. Our review found strong correlations between hypometabolism and specific brain regions identified by FDG PET and improved seizure control post-surgery, with sensitivity and specificity for seizure outcome predictions ranging from 70 to 89%. The graph on the right illustrates the relationship between thalamic metabolism, as detected by PET imaging, and post-operative seizure outcomes. We see Engel Class 1A outcomes representing seizure-free states, while Engel Class 1B through 4 include patients with rare to occasional seizures or those who did not achieve complete seizure freedom. Patients with thalamic hypometabolism had significantly different seizure-free rates compared to those without thalamic hypometabolism, with a statistically significant difference of p less than 0.05. An important insight from a study by Higo and colleagues in 2016 highlights the predictive value of FDG PET, particularly when combined with 3D SSP analysis for surgical outcomes in temporal lobe epilepsy. Their research found that hypometabolism in specific regions, particularly in the temporal lobe ipsilateral to the planned resection site, is strongly associated with positive post-surgical outcomes. This was especially notable in areas such as the hippocampus and amygdala, where hypometabolism served as a statistically significant predictor for seizure control. By pinpointing hypometabolic regions, PET helps guide more informed and precise resection decisions, offering a promising outlook for improved surgical success in patients with temporal lobe epilepsy. The ratio of hypometabolism difference, RHD, between good and poor surgical outcome groups reveals that in patients with favorable outcomes, the RHD ipsilateral to the surgical side was significantly higher across all regions of interest. In contrast, this significant RHD was not observed in poor outcome groups. This is also p less than 0.05. Compared to perfusion MRI, PET imaging demonstrates similar or even slightly superior sensitivity in identifying seizure foci, particularly in MRI-negative patients. While perfusion MRI detects cerebral blood flow changes, these may not always align with the metabolic abnormalities PET identifies. MRI remains effective for detecting structural lesions, but its limitations in identifying non-structural abnormalities makes PET a valuable complement in pre-surgical planning. Electrophysiological methods, including ECOG and SEEG, provide excellent spatial and temporal resolution for pinpointing seizure foci, but are invasive, requiring intracranial electrode placement. PET, as a non-invasive option, complements these methods well. Studies show that combining PET with EEG and even invasive methods like ECOG or SEEG improves localization accuracy and post-surgical outcomes. For instance, combining FDG PET with ECOG or SEEG enhances the epileptogenic zone detection, especially where surface EEG falls short. To conclude, PET, particularly in combination with MRI and EEG, is a powerful tool for preoperative planning in ATL. Despite some challenges, such as cost and radiation exposure, PET holds considerable promise for improving outcomes in TLE patients resistant to medications. PET MRI fusion, which combines PET's metabolic data with MRI structural detail, offers enhanced localization and improved surgical planning, ultimately advancing the treatment landscape for patients with temporal lobe epilepsy. I would like to acknowledge my co-authors and my mentors for making this research possible, as well as Dr. Brem for his support and mentorship regarding this presentation. Thank you.